Well, I looked over your labs and everything looks great, so I'll see you next year. Does that sound anything like your annual checkup? Unfortunately, when it comes to your kidneys, if you and your doctor are relying on the standard blood test, creatinine, that reassurance might be a big mistake. So, if you don't want dialysis to be part of your retirement plans, stick around to learn how you can detect the early stages of kidney disease before it's too late. Oh, and if you have high blood pressure, diabetes, or take ibuprofen like it's a cookie, this information is even more important. But as always, we will try to have some fun while learning. I'm Dr. New, and today we are diving deep into how the most common blood test done by doctors may not reflect the real function of your kidneys. We will learn why muscle mass can greatly skew our interpretation of this lab, and why many doctors may not appreciate this effect. And I will suggest a couple lab tests that better reflect the longevity prospects of your renal system. To understand this problem, we have to look at some history. Let's go back to the early 20th century. No, much further back than that. Further. Okay, that's about right. Even back in the early 1900s, scientists knew that the kidney's purpose was to filter blood to help remove waste products that our body created. They could see the waste by looking at the components of urine, but they needed a way to see how well those filters were operating. So some nerds that are way smarter than me figured out a genius approach. They injected a foreign chemical substance into the blood and then waited to see how long it took a person to pee out. It was a great way to measure this. We call it GFR, that's glomerular filtration rate. Say that 3 times fast. The faster the substance is removed from blood and put into the urine, the better the kidneys are operating. If we adjust for body size, a direct measurement of GFR using this method is incredibly accurate. But it's a total nightmare to do in a busy medical clinic. At least I don't think my patients would appreciate staying here all day long just to pee in a jug. So the lab nerds back then looked for a shortcut to estimate GFR with a single easy blood test. They needed something always floating around in a person's bloodstream in relatively stable amounts. And they found creatinine. It's a waste product of skeletal muscle cells. So every person makes this naturally in roughly the same-ish stable amounts at all times. More on those caveats soon. So by the late 1930s, labs and doctors were using creatinine to estimate GFR, or kidney function. I suppose in clinical practice, it still is considered good enough by most doctors. But maybe after 100 years, we should probably approach this in a smarter way. Let's look at why creatinine can fall short. When you see eGFR on your lab results, that E stands for estimated. In medicine, that's a fancy way of saying we're guesstimating. It's like when I estimate I'll be home by 5 p.m. My wife knows there's a high margin of error there. With this blood test, we aren't directly measuring your filtration ability. We are using a math equation to guess it based on how much creatinine is found in your blood. Now, here's the fundamental flaw. Creatinine isn't just a kidney marker. As we learned, it's also a muscle marker, a normal, everyday waste product produced by our muscles. So the level of creatinine in your blood is determined by a balance of these two forces. How much is created by your muscles, and how fast are your kidneys clearing it? The estimation equation assumes you have a statistically average amount of muscle based on your age, gender, and sometimes race. But as a doctor, I can tell you, not all individuals are average. Or as many of my patients like to tell me, "Doctor, I'm not normal." Now, let's look at the wide spectrum of muscle mass among people and see the big reason why GFR math may fall apart. Maybe you're a gym bro or gym girl, or you lift heavy stuff at work every day, play sports, or just have a genetic gift for a buff physique. Either way, if you have a lot of skeletal muscle compared to the average Joe, or you will produce a mountain of creatinine waste every day. This isn't a bad thing. In this case, the lab will see a higher level of creatinine, and the equation will spit out a low eGFR. But it's not because your kidneys are failing to clear waste products. This is a falsely low eGFR. Sadly, some muscular people will even get a scary phone call from their PCP about potential kidney disease that they don't actually have. I've seen this quite a few times in my career. And while annoying, upon further consultation with a nephrologist, these patients can get reassurance that their kidneys are actually working just fine. Now, what about the not so muscular people? This is a much bigger, or perhaps I should say more common issue, and where real harm can occur. As our society has become increasingly sedentary, we, on average, at least many people, have lower muscle mass than previous generations. So if a person doesn't have a manual labor job or hasn't been pretty proactive about maintaining their strength and muscle, it's somewhat likely they will have a relatively low level of muscle mass by the age of 40 or 50. And if they had a sedentary childhood, this could occur at even younger of an age. If you don't have very much muscle mass, you aren't producing that much creatinine. Your waste is tiny. Your kidneys could actually be struggling. The filters could be half broken. But because there is so little creatinine being put into your bloodstream, your lab could be perfectly normal. The computer sees that lowish level of creatinine and gives you a falsely high GFR estimate. Basically, you're being told everything is fine when your kidney function is silently slipping away. And I fear we are missing many cases of chronic kidney disease until things are pretty advanced. But here is the real sobering review of the natural age-related decline of our kidney function. To some extent, this is just inevitable. Starting around age 30, the average human loses about 8 to 10 points of GFR per decade of life. Think of it as a biological tax. If you have chronic conditions like high blood pressure, diabetes, or prediabetes, this rate of decline can be much quicker than this, like at least double. Even things like regular use of ibuprofen or NSAIDs can slowly erode your kidney function. You might ask, well, how much function do I need to be okay? We categorize this into stages, but anything below 30 is considered severe or stage 4 disease. People can start to feel vaguely crummy at this level of kidney disease. If GFR dips below 15 or 20, a person is looking at end-stage disease, which means the kidneys cannot filter waste products very much at all, which is incompatible with life, unless they start dialysis a few times per week or get a kidney transplant. And neither one of those is very fun or without risks. So let's say at age 40, you have a GFR of 100. With average decline by age 60, your GFR will be 60. If you live to be 90, you'd still have a GFR of 40, which is perfectly still functional. Now, I hate to be the bearer of bad news, but very few people will live to see 100 years. But even if you did, your kidneys would be working well enough at this rate of decline. Now, imagine you're 40 years old and your real GFR is 60. If you continue that 10 point per decade slide, by the time you're 70, you're hitting a GFR of 30 or lower. That is severe kidney disease. If you're lucky enough to live to be 80, you are approaching end stage. But because of the creatinine muscle error, at age 40, you are being told it's actually 80 and fine. So understanding this trajectory while you're relatively young, and I'm in my 40s, so I will still consider that young, is wise. Otherwise, you may be surprised when you need to visit a dialysis clinic 3 times a week instead of that golf course, or whatever else you plan to do in retirement. So if the old school lab test has this potential error, how do we get a better GFR estimate with simple lab tests? First, we add a blood test called Cystatin-C. No, it's not related to the statin class of medications. That's another lecture for another day. This is a protein produced by almost every cell on our body at a pretty constant, steady rate, with levels not varying as much among individuals based upon muscles and other factors. If we estimate your GFR using Cystatin-C, in many cases, it is much closer to a true GFR. This is true of buff people or you couch potatoes. When a person is relatively healthy without obvious Cystatin-C confounders, I will use that lab solely to determine GFR. If a person's health is more complex with things that could alter Cystatin-C levels, the best estimation of GFR is actually combining the creatinine and Cystatin-C. Why don't we use Cystatin-C lab for everyone? Well, other than the inertia of the American healthcare system, I suppose it's cost. This is a $40 to $80 test versus a $4 test that's included on a standard chemistry panel. And many insurance companies won't approve this lab unless it's justified. But if we are trying to see if that 40-year-old is headed for a disaster at 70, that is a pretty small investment compared to the crazy amount of money Americans spend on healthcare each year. Do we need to get a Cystatin-C lab on every person every year? Probably not. My general approach is to check it at least once to see if it matches up with your eGFR by using creatinine. If there's not a big discrepancy here, we can continue to use creatinine yearly and maybe recheck Cystatin-C level every 3 to 5 years. Finally, we have to look at the urine leak test. No, I'm not referring to people who need to rely on Depends. Even if your GFR looks okay, we can check to see if the filter itself is physically intact. We've talked about the kidneys removing waste and putting it into the urine, but they should also keep the good stuff inside your bloodstream. One example of that is the protein albumin. We don't want that stuff spilling out into our urine. So if we find very much albumin in your urine, it means the kidney filter or screen has big holes in it. We can measure this with the urine albumin-to-creatinine ratio. Think of this as your check engine light for leaky kidneys. It often turns on many years before GFR starts to slide. And this is a relatively affordable lab test and doesn't even require a blood draw. So checking this yearly, if you have risk factors such as high blood pressure or diabetes, is smart. But even if you're healthy, checking this every few years is really cheap reassurance. Chronic kidney disease is common, it is silent, and it's coming for us all, if something else doesn't get us first. So let's not solely rely on a 100-year-old lab estimate. If your labs don't seem to match your body type, or you just want to know your real kidney status, talk to your doctor. Ask them for a Cystatin-C and urine albumin test. Well, I guess you've made it this far, so you better understand the lab tests related to your kidneys. Or at least I didn't bore you into clicking away. So if you like this type of content, feel free to make some suggestions about other topics in the comments section, and I'll try to cover. Also, another ask, if you have a family member or friend who may be at risk of kidney disease, please share this video with them. As a primary care doctor, the worst thing I see is people waiting too long to address an underlying health problem. Sure, modern medicine can do amazing things for us sometimes. But as Ben Franklin said, an ounce of prevention is worth a pound of cure. But maybe in our expensive healthcare system with high deductibles, perhaps it's more like a ton.